Good evening to everyone present here with us today. This is Rion from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned Doctor, Dr. Shalini Jagti. Ma'am is consultant diabetologist and director at Life Care Diabetic Center, Kritinagar, New Delhi. With the help of ma'am and her wonderful insight, we will be taking a close look on today's topic, which is pathopsychology of hyperglycemia in pregnancy. Now, without any further delay, I would like to welcome ma'am at our forum and would like to hand over the session to her. Over to you.
Thank you so much. So, a very good evening to everyone who's present today to listen to this presentation on pathophysiology of hyperglycemia in pregnancy. I think all of us have been treating different types of diabetes in pregnancy, and there's a lot of confusion even on the nomenclature and definition. So, let me start by just showing you this one slide, which actually puts all kinds of dysglycemias in pregnancy under the umbrella term of HIP, and this is something that the WHO and FIGO have agreed on. So any type of dysglycemia in pregnancy has been labeled as an umbrella term of hyperglycemia in pregnancy, and this includes three different entities as you can see here. Pre-gestational diabetes or pre-GDM is women who already have pre-existing diabetes, which could be type 1, type 2 or any of the other forms of diabetes before pregnancy. So this is a category of women who already have diabetes before pregnancy and then they get pregnant and we manage them accordingly. Now, women who do not have diabetes or who are not aware of diabetes, but diabetes is diagnosed for the first time in pregnancy, we were calling them gestational diabetes, but now we know there are two different minute differences. So, on the one hand, you have a category of women who are labeled as diabetes in pregnancy or DIP. Now, these are women who are diagnosed with hyperglycemia for the first time in pregnancy, but the criteria of their glycemic levels is something that is the same as the WHO criteria of diabetes in the non-pregnant state. So that means their fasting is already more than 126 or their post meal is already more than 200. So these are primarily women who do have overt diabetes but probably were not aware of their diabetic status but have been picked up in pregnancy, and usually this happens in early pregnancy in the first trimester itself. So all these women are categorized as DIP or diabetes in pregnancy. And then you have the typical term of gestational diabetes, which is diabetes that occurs anytime in the antenatal period in the pregnancy and is not expected to persist postpartum, and you have ruled out overt diabetes in these women. So they definitely did not have diabetes before pregnancy, but the diabetes has developed during pregnancy, essentially in the second or the third trimester. So these are women who are clubbed under the term of gestational diabetes. Now, today we are going to talk on the pathophysiology of hyperglycemia in pregnancy. So why does diabetes develop in pregnancy is what we are going to discuss. Now, before we go to what exactly happens as a pathophysiology, let me talk about normal physiology of pregnancy first. Now, why does maternal metabolism change in pregnancy is the first question. Well, in pregnancy, the metabolic adaptations that occur in the body of the woman are primarily to accommodate the rapidly growing tissue transplant or the conceptus. And for its normal growth and development, this conceptus or this fetus brings about alterations in the maternal fuel metabolism and hormones, and all this is facilitated by the placenta. So placenta has a role in facilitating embryogenesis, growth, maturation and survival of the fetus with the help of all these hormones, the steroid hormones and the peptide hormones that are produced by the placenta, and to modulate and transport the maternal fuel to the fetus. So all the maternal metabolic changes that occur in pregnancy basically are designed to create an uninterrupted supply of nutrients from the mother to the fetus for its growth and energy needs. Now, the metabolic goals of pregnancy, like I said, are primarily to have fuel available for the fetus for its growth and energy needs. So how does metabolism change in pregnancies? Well, in the first stage, the early pregnancy, it is basically to develop anabolic stores which eventually will be needed to meet the metabolic demands that will occur in the later part of pregnancy, and entire function is taken care of by the placenta. So we all know two main hormones that have a role to play are insulin and glucagon. Insulin we all know as an anabolic hormone, glucagon is the catabolic hormone, and the coordinated action between these two hormones will maintain the maternal plasma glucose. So in the first half of pregnancy, what we see is what is called facilitated insulin action, and second half of pregnancy, what you see is all these hormones that come into being, which lead to a diabetogenic stress and cause an increasing amount of insulin resistance in the body of the mother. And I'll take you through the metabolic changes at the molecular level. Now I'm talking about a normal pregnancy right now, because then only will we be able to understand the pathophysiology or the abnormality that happens in gestational diabetes, or when we say a woman has diabetes in pregnancy. So in a normal pregnant woman who does not develop diabetes, a normal pregnancy, what happens is in the early pregnancy, because of these hormonal alterations, estrogens, progesterones going up, there is a state of beta cell hyperplasia and increased insulin secretion, resulting in hyperinsulinemia. So because of this, what happens is the insulin mediated glucose disposal goes up. So on the one hand, you will see increased peripheral glucose utilization and building up of the tissue glycogen stores, because we need anabolism for the fetus to actually grow and develop. The hepatic glucose production comes down. The insulin sensitivity overall improves in early pregnancy. And that is the reason why the fasting plasma glucose in a pregnant woman is reduced in early pregnancy, and therefore all we see is the anabolic metabolic changes happening in early pregnancy. Now as the pregnancy advances to the second and the third trimester, I told you, because of all these diabetogenic hormones, the placental hormones, cortisol, prolactin, we are seeing an increase in the insulin resistance and a reduction in the insulin mediated glucose disposal that occurs at the periphery, at the skeletal muscle, at the adipose tissue level. So this progressive increase in insulin resistance is occurring. Furthermore, you see alterations occurring in adipokines, you see inflammatory markers coming in. Because of all these, there is a huge increase in insulin resistance, and to make up for that insulin resistance, there is a compensatory increase in insulin secretion almost to the amount of 200 to 250% increase in insulin secretion that occurs in the later part of pregnancy to make up for this insulin resistance and to keep the glucose levels in the normal range so that the mother does not develop hyperglycemia. So Norman Frankel actually very beautifully described these changes by saying that the fetus, you have to imagine this as a fetus being a continually feeding border inside the body of an intermittently host, the mother. So all the time metabolic change has to be such that the fetal plasma glucose is maintained so that it gets all its nutrients for its growth, for its further development, and the mother's glucose levels are also maintained in the normal range, and that is why you see all this metabolic shift occurring. So when the mother is not eating, that means in the unfed state, what is happening is to meet the fetal glucose demands, there is a continuous shunting of carbohydrate to the fetus, hepatic neoglucogenesis increases, and the peripheral insulin resistance develops. So because of this, what happens is fasting insulin levels go up and the maternal fasting plasma glucose comes down. That is the reason why in a non-diabetic mother in early pregnancy, you will see fasting glucose in the range of 70 to 80. Now, as the pregnancy advances, there is still a constant shift of glucose to the fetus, so the fasting continues to be low. But like I said, gluconeogenesis is also occurring in the liver. So the amino acids are being used up to produce more and more fuel for the baby's growth, and therefore you see a reduction in the circulating amino acids, especially alanine. Now what is happening is protein is still required for the fetal growth. So therefore the maternal metabolism has to be such that protein can be spared for the baby. So the mother has to use less and less of protein for her energy, and that is why the maternal metabolism will shift rapidly to catabolic metabolism by using fat as a fuel source. So what you see when the mother is not eating or in an unfed state is a state of accelerated starvation and a tendency towards ketosis, because now instead of utilizing protein, she is shifting to using fat as a fuel source. Now what happens when she's eating? In the fed state, when she's eating a mixed meal, she will get all these nutrients, glucose and all these nutrients that are present. They will be all the substrates that will be used again for the fetal growth. So the basal and glucose stimulated insulin release will be increased in pregnancy, and the post-meal glucose load along with this increasing insulin levels will kind of blunt the glucagon secretion from the alpha cells. So all this extra insulin that is being produced, it will compensate for the peripheral insulin resistance that is occurring, plus it will blunt the gluconeogenic potential of glucagon in the immediate post-meal period, because now in the immediate post-meal period, carbs and all these nutrients are available. So the amino acids will be spared for anabolic use both for the mother as well as the fetus, therefore producing a state of facilitated anabolism in the fed state. Now once the carbs are disposed, the alpha cell responsiveness to the persistent hyperamino acidemia will stimulate at least enough gluconeogenesis to prevent reactive hypoglycemia in the mother. So that is why, although the glucose levels are coming down, although there is excess of insulin present, the mother is not going into hypoglycemia because some amount of alpha cell responsiveness is still maintained. Therefore, friends, in a normal pregnancy, the maternal fuel metabolism is characterized simply by a state of accelerated starvation in the unfed state and facilitated anabolism in the fed state. So this is what is happening in a normal pregnancy. So like you can see, all these hormonal changes have a diabetogenic effect. So you will see a massive increase in insulin resistance. You will see a breakdown of the hepatic glycogen stores. You will see increased neoglucogenesis, increased hepatic glucose production, and therefore in the fed state there is a facilitated anabolism, and in the state when she is fasting you will see catabolism. So there is accelerated starvation in fasting, and that is the reason why normally in pregnancy we tell women not to fast, because the metabolic changes of fasting on deprivation of food that would take about 72 hours in a non-pregnant woman, in a non-pregnant state, they will happen very fast because of this metabolic shift that is happening, and within 18 hours of fasting she can go into ketosis. So that is why pregnant women are advised not to fast for long hours. I hope this is very clear now. So in a normal pregnancy, when the woman does not develop dysglycemia, you will see fasting stays about 71 plus minus 8 on an average, and the 1 hour and 2 hour values will be less than 122, and glucose levels stay less than 110 at about 2 hours. Now this is something which is very beautifully maintained by nature during pregnancy in all the women who are not predisposed to gestational diabetes or diabetes. So what actually goes wrong? Why does a woman develop gestational diabetes in pregnancy? Well, like I told you, initially there is a progressive change in maternal metabolism. You can see here on the screen, as the glucose levels are going up, you can see a massive increase in insulin secretion that is happening. So there is this progressive increase in insulin secretion will enable the mother to maintain plasma glucose levels in normal ranges following a glucose load. But when this compensation fails, she will develop GDM. So in GDM, usually what you will see is beta cell dysfunction occurs on a background of a woman already at a risk of GDM. And I'll come to the risk factors in a little while. There is a background of chronic insulin resistance already present, and on which the add-on insulin resistance of pregnancy works as an additive fraction. So there is a greater degree of insulin resistance that will develop in women who have a risk for developing GDM. Now, what is so basically, putting it in simple terms, insulin secretion and insulin resistance, when they are equal to each other, it stays normal in a non-pregnant state. Now, when she becomes pregnant, there will be a massive increase in insulin resistance, and the insulin secretion, if she is able to compensate, it will take care and the glucose levels will stay normal. But if the insulin resistance increases to a certain extent that she already has chronic beta cell dysfunction and is not able to produce as much insulin as is required to take care of this entire insulin resistance, she will develop gestational diabetes. Now, abnormalities occur in at least 3 aspects of fuel metabolism the exogenous fuels in the fed state. So there'll be reduced facilitated anabolism, and there will be hyper accelerated starvation or overproduction from endogenous sources in the fasting state. So all these diabetogenic hormones will result in a sluggish first phase insulin secretion in association with increased insulin resistance. Now, what are the risk factors for developing GDM? Any woman who is overweight, obese, BMI more than 30, or advanced age of maternal pregnancy, when she is beyond 25 years of age, somebody who's got a
Um, Ma'am, sorry to interrupt. Your device got disconnected. Can you please rejoin again? Yeah. Yes, ma'am. Am I audible to you? Shali, ma'am, am I audible? Can you please unmute
I
yourself, ma'am? Yeah.
think there's some problem. I'm getting muted. My yeah.
Yes, ma'am. Your camera is off. Can you please switch it on? Your device got disconnected again.
Some problem, I think. I'm
Sorry.
trying to switch it on. Yeah, it's automatically getting switched off. I don't know why.
Some
Automatically it's going
technical
off.
issue maybe. It's okay, ma'am. You can continue without your video, I think.
Yeah, so I'll continue without the video.
Yes, ma'am.
Okay. Okay. So the risk factors on who will develop GDM are many. Most important being a woman who's overweight or obese, somebody who's got an advanced maternal age beyond 25 years, somebody who's got a family history of diabetes, maybe parents being diabetic or a first degree relative having diabetes, somebody who's got PCOS, having delivered a macrosomic baby weighing 4.5 or more, or somebody who's had a history of GDM in a past pregnancy or a deranged GTT, and especially ethnicity. Southeast Asians, Indians, Pakistanis, all of us are predisposed to GDM. Somebody who's had a bad OBS history or has gained a lot of weight in pregnancy. So, Indian women data shows already have an 11-fold increased risk of developing glucose intolerance in pregnancy in comparison to the Caucasians. So, each of these risk factors will directly or indirectly lead to impaired beta cell function and reduction in insulin sensitivity, increase in insulin resistance. Therefore, friends, GDM actually is now known as a stage in the evolution of type 2 diabetes. Multiple pathophysiological mechanisms. I talked about beta cell dysfunction, chronic insulin resistance. These are leading to a vicious cycle of hyperglycemia because the woman will already have beta cell dysfunction to start with, and then she gets pregnant. The diabetogenic hormones are going to cause an increase in the insulin resistance, and further beta cell dysfunction is set into motion. So basically, the rate of insulin stimulated glucose uptake is reduced by almost 54% in women with GDM compared to a normal pregnancy. Again, on a molecular level, we see an altered expression and phosphorylation of downstream regulators of insulin signaling. So, the IRS1, PI3 kinase, GLUT4, all of these have been described in GDM, and many of these molecular changes may persist beyond pregnancy. And that is why we say that a woman who's had GDM eventually is at a very high risk of developing type 2 diabetes later in pregnancy. So, further on, like I said, as the on a background of beta cell dysfunction, the insulin resistance is also going up. And then, like I talked about the adipokines and the cytokines coming into play, pro-inflammatory cytokines, adiponectin, they will further lead to a metabolic dysfunction predisposing to increasing insulin resistance. So, like you can see in this diagram, in a normal pregnancy, the insulin sensitivity is normal. When she gets pregnant, you will see a slight reduction in the insulin sensitivity that occurs. So as the glucose levels will go up, the pancreas is able to compensate by producing more and more insulin when the beta cells are normal and the pancreas are healthy. Now once, so therefore her glucose levels will be normal. She will be a normoglycemic pregnancy. And once the she's delivered, the insulin sensitivity returns to normal, so the glucose levels can be normalized by a normalization of the beta cell function. But for a woman who is predisposed to gestational diabetes, what you will see is, even before pregnancy, certain amount of insulin resistance may already be there. So maybe some amount of chronic beta cell dysfunction may already be present even before she conceives. So once she gets pregnant, I talked about the massive reduction that occurs in insulin sensitivity at a molecular level. So the glucose levels start going up. But unfortunately, the compensatory hyperinsulinemia does not happen, and therefore her glucose levels remain deranged. And even after the pregnancy, a slight improvement does occur in the insulin sensitivity but does not normalize, and therefore chances are that she continues to remain pre-diabetic and may eventually progress to type 2 diabetes later on after the delivery.
Ma'am, your device again got disconnected.
Yeah. So am I, can you hear me now?
Yes. Yes,
Yeah.
yes, ma'am.
So GDM is again associated with reduced adipocyte differentiation and increased adipocyte size. There's adipocyte hypertrophy. There's a down regulation of gene expression of insulin regulators. There's glucotoxicity, lipotoxicity. Adipokines come into play, and therefore all of these eventually result in increasing insulin resistance. Now we also know that there is the role of gut microbiota in GDM. We know the good microbes and the bad microbes. A balance has to be maintained between them. However, in women who are predisposed to gestational diabetes, you see that the good bacteria or the firmicutes, they reduce, and the bad bacteria, the prevotellacea, they increase. Now what happens is, when these bad gut microbes increase, the prevotellacea, these are mucin degrading bacteria which increase the gut permeability, and therefore all these inflammatory mediators can clearly pass from the gut to circulation, further by causing a systemic insulin resistance that may happen in the body of the mother. Plus there's oxidative stress, there's overproduction of free radicals, all of these worsening the hyperglycemia in pregnancy. So multiple pathophysiological mechanisms you can see in hyperglycemia in pregnancy, as you can see in this diagram. And therefore it is important that we maintain a good birth weight for the baby, to prevent this baby being born with either a low birth weight. When there is maternal undernutrition, this again leads to a wrong fetal programming for the baby, leading in structural changes in the child. And then there's catch up growth as per the Barker's hypothesis. So these are the children who are at a higher risk of developing NCDs in the future. And again, if the mother is obese or has gained a lot of gestational weight or develops GDM, maternal overnutrition also causes epigenetic changes in the genes of these babies, predisposing them to an increased risk of obesity and diabetes or CVD in the offspring. Therefore, it's important that it starts right from the beginning. So, a baby who is born with an optimal birth weight without any exposure to maternal undernutrition or overnutrition, then only the NCDs can be stopped. So, friends, to conclude, pregnancy is a state of high metabolic activity in which maintaining glucose homeostasis is very important. So, it is likely that genetic, epigenetic, and environmental factors all contribute to development of dysglycemia in pregnancy, with complex mechanisms that I told you over a substantial period of time. However, suffice it to say, essentially, it is the pancreatic beta cell failure to compensate for the chronic fuel excess, leading to eventual insulin resistance, hyperglycemia, and an increased supply of glucose to the growing fetus. So, insulin resistance is a result of the combination of increased maternal adiposity and the insulin desensitizing effects of hormonal products of placenta. So there's a lot of evidence now that adipose expandability, low grade chronic inflammation, gluconeogenesis, oxidative stress, altered gut microbiome, and placental factors all contribute to pathophysiology of GDM. And we need a better understanding of these processes and their contribution to dysglycemia in pregnancy to develop effective treatment and prevention strategies. With that, I think I'll stop sharing my slides, and we can open up for a few questions.
Thank you so much, ma'am, for this wonderful presentation. We do have some question if you like to take that up. Hello.
Yes.
Yes, ma'am. I was saying we do have some question if you like to take that up.
Yes, yes, please. Why not? I'm
Sure.
sorry, there's some problem through the server. I'm not able to put my camera on.
Not an issue, ma'am. We can continue like this.
Sure.
So, ma'am, the first question is, what are the key molecular mechanism underlying resistance in pregnancy?
Sorry, I your voice is not. Can you repeat the
Ma'am, you
question,
just
please?
switch off your camera because I think you're trying to switch it on, because of which there is some audio issue from your end as well.
Yeah. Okay, tell me.
Ma'am, the question was, what are the key molecular mechanism underlying insulin resistance in pregnancy?
That's exactly what I explained. The insulin signaling pathways, the increasing insulin resistance, all of these on a background of chronic beta cell dysfunction. There's already a background of chronic beta cell dysfunction. And then when the woman gets pregnant, all the diabetogenic stress of these hormones that leads to increasing insulin resistance, and therefore eventually she develops gestational diabetes or hyperglycemia in pregnancy eventually.
The next question is, ma'am, how does impaired lipid metabolism during pregnancy intersect with the hyperglycemia pathogenesis?
Yes, I showed you that slide where there is adipocyte hypertrophy, number one, that leads to a adipocyte dysfunction. And then I talked about the chronic inflammation. So you have the lipotoxicity also coming in, adipokines are produced, and all these different adipokines further worsen the the chronic inflammation, and they worsen the insulin resistance. So basically, anything that is causing a progressive increase in insulin resistance, it could be from any of the mechanism, that will eventually lead to dysglycemia or development of gestational diabetes. So I think it's important to understand, be it lipotoxicity, be it glucotoxicity, all of them on a background of beta cell dysfunction and chronic inflammation will cause progressive increase in insulin resistance and development of dysglycemia.
Ma'am, one of our audience is asking, can women of 18 plus age takes HPV vaccine to prevent cancer, or it doesn't work?
I think this is out of context, but yes, although the best time to take HPV vaccine is right in the beginning, very early on, even before her menarche, that's the best time when it works, because then she gets and before she gets sexually active. That is very important to prevent exposure. That is the best time to take the HPV vaccine. But then, of course, if she has not been vaccinated, what our obstetrician friends say is, even before resuming sexual activity, she should definitely get herself vaccinated. So even if at 18, if sexual activity has not yet started, definitely some amount of protection she may still get.
Thank you, ma'am. There is one last question. What are the difference in the pathopsychology of hyperglycemia in GDM compared to pre-existing type 1 and type 2 diabetes in pregnancy?
Okay. So gestational diabetes, like I clearly said, is basically she does not have diabetes before she's pregnant. She may have some risk factors. She may be obese. She may already have some amount of insulin resistance. She may be overweight. Her age may be on the higher side. She may have some first degree relative. So she has the risk factors. Then when she gets pregnant, usually in the second trimester or the third trimester, because of the pregnancy hormones that are produced for the fetal well-being, all these hormones will lead towards insulin resistance and she will develop diabetes. So that is gestational diabetes. But in a woman who is already having diabetes before she's pregnant, so type 1 or type 2, there again what is happening is already diabetes is present. So if it is type 1, then we already know there is no beta cell function. She is already not producing insulin. So definitely she is somebody who has to be on insulin all through the pregnancy. But the hormones that are produced, the diabetogenic hormones, are still being produced in the type 1 also. So these will further produce a state of insulin resistance. She already is insulin deficient. Now when the insulin resistance is increasing, her insulin dose requirements will go up. Therefore, for all type 1s, we say that you have the insulin doses progressively keep increasing. In the beginning, I showed a slide where I said that initially there is an improvement in insulin sensitivity that occurs right in the beginning. So, in a woman who is already on insulin, a type 1, there we will see that in the first trimester, insulin doses may go down a little because of this improved insulin sensitivity. But eventually, in the second and the third trimester, as the pregnancy hormones are increasing, insulin resistance will increase and the doses will start going up. So you see almost a 5 to 10% increase in doses occurring every week. So the non-pregnant dose versus the dose that she needs in pregnancy could be 2 to 3 times. And the moment she delivers, all these diabetogenic hormones are taken away. The placental hormones are completely gone. The placenta is out of the body. The insulin resistance improves and she goes back to the non-pregnant insulin doses for a type 1. In a type 2, the physiology will be little different. Type 2 will already have some amount of insulin resistance in the body. So, for her, again, the pregnancy hormones will worsen the insulin resistance that is already present. So, again, she will need a lot of insulin to take care of this, to get the glucose levels in the normal range. And in pregnancy, it is important that you increase insulin to maintain a fasting between 70 to 90, less than 95, and a 2 hour post meal value should strictly be maintained between 100 to 120. So the insulin doses will go up massively in a patient with type 2 diabetes. So there you should just tell her to do frequent self monitoring of blood glucose and increase the insulin doses so that a fasting of 70 to 90 can be maintained and a 2 hour post meal value of 100 to 120 can be maintained.
Thank you so much, ma'am, for answering all our questions. That's all from our audience. So, ma'am, before concluding, any take home message from your end?
I think my only take home, because I work a lot in this diabetes and pregnancy field, so it's very important that all of us are sensitized to the fact that uncontrolled diabetes in pregnancy can lead to a lot of adverse maternal and fetal outcomes. So it's important that all pregnant women should be screened for diabetes even before pregnancy, even if they don't have a history of diabetes. There also, before she plans a pregnancy, she should understand that maintaining tight glucose levels is important. So ideally we should screen for GDM even before she gets pregnant. And if she has missed that screening in the first trimester, at the first visit to the obstetrician when she confirms the pregnancy, you should do a glucose tolerance test or a dipsy test to rule out any overt pre-existing diabetes. And then subsequently every trimester she should be screened for gestational diabetes. You can follow the DIPSY criteria or you can follow whichever criteria, but most important bottom line is GDM screening is a must. Ideally, prior to planning the pregnancy and then in the beginning of pregnancy, then if it is negative in the second trimester and the third trimester, and whenever she is picked up, glucose should be maintained very tightly between fasting, like I said, 70 to 90, post meal 2 hour value between 100 to 120. So all women with diabetes, I think it's important they are screened and managed well to tight targets with insulin to bring them to normal levels so that maternal and fetal complications can be avoided.
Thank you so much, ma'am, for joining us today. Thank you for this wonderful session. With your permission, ma'am, I would like to conclude today's session. Thank
Thank
you.
you so much. Thank you. Bye.
Bye, ma'am.